When discussing the relationship between food and chronic disease, it's easy to frame it in terms of personal choice. Eat better, move more, and avoid harmful ingredients. But that narrative oversimplifies a reality that's far more complex and far more unjust. Across the globe, and especially within underserved communities, access to nutritious food is not an equal opportunity. Chronic disease isn't just the product of bad choices. It's often the result of structural inequality, systemic neglect, and deeply embedded barriers to healthy living. Any serious discussion about food and public health must begin with this truth. You can't choose what isn't available, affordable, or understood. In low-income neighborhoods, both urban and rural, the term food desert is more than a metaphor. These are places where fresh fruits, vegetables, whole grains, and lean proteins are hard to find, and where fast food, corner stores, and ultra-processed snacks dominate the food landscape. Supermarkets may be miles away, public transportation unreliable, and time or money to shop limited. In this environment, cheap, calorie-dense, nutrient-poor food isn't just tempting, it's often the only practical option. And that sets the stage for a lifetime of poor health outcomes, from obesity and diabetes to heart disease and stroke. But the problem doesn't stop at geography. Income inequality plays a massive role in shaping food choices. Even when healthy options are available, they're often more expensive, both in absolute cost and in terms of time, energy, and preparation. Cooking a balanced meal requires not just ingredients, but kitchen equipment, electricity, and free time. Luxuries that millions of working families and single parents simply don't have. Meanwhile, processed foods are aggressively marketed, easy to prepare, and designed to hit all the biological reward centers with sugar, salt, and fat. For families living paycheck to paycheck, the choice between a $1 burger and a $6 salad is not a real choice at all. Nutritional education and literacy further compound the issue. Schools in underfunded districts may offer little to no instruction on food, cooking, or long-term health. Parents raised in environments of scarcity may not have had the chance to learn about balanced nutrition, or may distrust mainstream dietary advice shaped by institutions that have long ignored their needs. Add to this the psychological toll of stress, food insecurity, and exposure to trauma, all of which are linked to increased consumption of comfort foods and poor dietary regulation, and the pattern becomes clear. Chronic disease is not simply an individual failure. It is a systemic one. There is also a racial and ethnic dimension to this crisis. In many countries, including the United States, Black, Latino, and Indigenous communities disproportionately suffer from diet-related illnesses. These disparities reflect a legacy of housing discrimination, labor exploitation, and environmental injustice, all of which have shaped where people live and what they can eat. Food advertising often targets these communities with unhealthy products, while government safety net programs remain underfunded or stigmatized. Even well-intentioned public health efforts can miss the mark when they fail to address the realities of inequity. Telling someone to eat more vegetables is meaningless if they live in a neighborhood where the only greens are wilted iceberg lettuce from a convenience store. Demonizing fast food ignores the fact that, for many, it may be the only affordable meal after a 12-hour shift. And promoting dietary guidelines without cultural sensitivity alienates communities whose culinary traditions are different, but no less valid. So, what's the path forward? It begins with shifting the conversation from personal blame to systemic responsibility. Policies must address not just what people eat, but why they eat it and what systems constrain their options. That means subsidizing fruits and vegetables, expanding urban agriculture, funding nutrition programs in schools, and ensuring all communities have access to clean, affordable water. It means regulating predatory food advertising, increasing the minimum wage, and supporting grocery infrastructure in underserved areas. And it means investing in culturally tailored education and community-led health initiatives that build trust and empower change from within. Equity in food access isn't a luxury, it's a prerequisite for meaningful progress in reducing chronic disease. Until we close the gap between what's possible and what's available, the burden of illness will continue to fall hardest on those with the fewest resources. And no amount of willpower can fix a broken food system, because in the end, health is not just about what's on your plate. It's about where you live, what you can afford, and whether the systems around you support or sabotage your ability to thrive.